So, as I said, we must look to resources. There are books on neuropathic entrapment syndromes. The main need to classify pain for me is really sometimes, of course, if it is peripheral, is it chemically driven or mechanically driven? So that's one thing. And or is it of a central? It is more centralized and chronic.
Right.
So that's it. But many times the pain presentation is so mixed that
Yeah.
that by itself the classification may or may not help you that much. You really have to now find out where the original cause is emanating, and we have to do it first in regions. Is so shoulder girdle and arm, hip girdle and leg as the four extremity limbs. They all contain the structures and the systems, whether it is lymph, fascia, nerve, ligament. They all have all this, and we must then go and look for information about how each of these systems behave when they are injured or damaged. Because
Let me ask
that
you, I was just going to say, maybe can you talk a little bit practically about what you're doing at the hip? You've ruled out the spine. There's
okay.
symptoms in the hip, in the lower extremity. You've ruled out the spine. Generally speaking, the person is either standing in front of you, lying on the table. How are you approaching that hip to rule these things in and out?
So depending on where the greatest concentration of tender points arise, that will start to get me to focus and see, are these tender points or the sensation of pain or discomfort local, or are they referred? That's the first thing I must know.
Actually, you've already done something. You're saying, I've palpated the entire lower extremity and found a chain of tender points?
I've screened that, yes. I've screened that. So I again repeat a kind of regional reassessment of what I had done globally.
Right.
I gather again the range of motion, the joint play, the strength of individual muscles within that extremity, the localization of trigger points or tender points. And then I have, as a reference, information from whether it is David Leaf or, as I said, all these other persons who have specialized in local areas of the leg. I now start going, okay, what could this be, and which systems are involved usually in this? So let's say I look at I think there's a piriformis problem. The patient has sciatic pain, but let's say they were weak. They had weak toe flexors, which when I turn out the leg are stronger. But if I turn in the leg and I put the piriformis on a stretch, these toe flexors go weak. Or when I put the other external rotators on a stretch, there is a weakening response in a distal muscle.
So let me backtrack. So you're saying, the patient has sciatic type symptoms.
Yes.
You've already ruled out their lumbar spine.
That's right.
You then regionally start to it's a regional global assessment again.
That's right. It's a regional assessment.
You manually muscle test some things around the hip, you palpate, and then in your mind you say, okay, but the patient has sciatic symptoms besides the lumbar spine. What is another thing that can cause
That's
this?
right. Exactly.
Piriformis syndrome can cause this. So
That's
let's
right.
stress the piriformis to
That's
see,
right.
just like I would have stressed the low back. I've already done
That's
that.
right.
So now
Yeah.
let's stress the piriformis based on the fact that they still have radicular symptoms down the leg.
That's right. So where else could this? It could be pinched in the behind the knee at the popliteus. It could be in the piriformis area. The fact that it is going down the leg at the back of the leg means I can rule out the cluneal nerves around the buttock. That will not likely be the area of focus. Um, uh, Sometimes the gluteus medius will give pseudosciatic symptoms down the back of the leg, but it is not likely to make the toe flexors weak because it is referred pain. So if by using these kind of reasoning logic, I start to focus and provoke the existing regional syndromes by the tissues that are known often to be dysfunctional. So I'm not rushing after the pudendal nerve because the toe flexors are weak. That's not logical. Yes.
Speak for yourself.
Well, but on the other hand, if somebody tells me that they have numbness in their crutch, well, then the pudendal nerve comes back and I start go, do you bike? Is there any way you could have compressed this acutely or accidentally? So it is really the scouring of the internet, looking up syndromes, problems that are considered pathological dysfunctions, and learning their presentations. That is what gives you.
You're scouring the
insight.
internet for presentations of lower extremity. I'm scouring for best bourbons under $60.
That's why. That's why you have a ways
how
to
you want
go.
to spend your free time. It's up to you.
That's right. Do you want to treat or do you want to drink? I think that is really what it boils down to.
Both treat and drink at the same time.
Yeah, you're into the. That's very un-American. You'd have to move to Europe. That's where you could drink during your breaks.
I'm trying to get there.
Yeah,
that's very funny.
So that is really it. So the pursuit of any information that can help you identify a syndrome is of absolute priority. And that is where, as a practitioner, you must be tireless. You must really be reading and looking up research and seeing what could help me understand better the clinical presentation of dysfunction. That's what you really need to know. Because if you start to do that, then you will go, wow, this looks like an endocrine problem because these things are missing, but these things are present. And I've read somewhere that given this triad, or these two things, it will make sense. It's like when my colleague, my partner had Graves' disease, the sudden weakness with trembling, but elevated heart rate. That was the giveaway that the heart rate was elevated. And not just the trembling and the muscle breaking weak. So these differential diagnoses are really important, and they are to be collated over clinical time. As a clinician, it takes years to gather this kind of information and put it away. But the sooner you can, the easier and the more cohesive your analysis becomes. When I started out, and for many years, each patient was not only an enigma, each patient was just trouble because I didn't know where to start. You know, the knee pain just represented a myriad of possibilities. But after a while, you could tell the meniscal pain and you knew what to do from the patella tendon pain, or the ACL ligament strain, or the lateral collateral ligament strain. You could tell it from the pes anserine problem. You could start to see that, you know, depending on where along the pes anserine the pain was, you could trace it to the sartorius muscle or the hamstrings and so on. And this is something that is just drudge work that must be done. I find it exciting, but it is still time consuming to.
If you enjoyed this conversation and want to hear more like it, then please like this video and subscribe to our channel. You can also stay up to date on our latest seminars on our social media pages on Instagram and Facebook at IMTR Seminars.